into these three divisions. You have an ophthalmic division called V1, and the V actually stands for cranial nerve number 5, and that's the first division, so ophthalmic division. Then you have V2, the maxillary division, and V3, the mandibular division. These three divisions will pass through for V1, the superior orbital fissure, for V2, through a round hole, so it's called the foramen rotundum, and for V3, well, that foramen is actually a little bit oval if we look at it, so it's called the foramen ovale. Yeah? This little hole, well, it's close to a spinous process underneath. That is the foramen spinosum, and that is important because the middle meningeal artery passes through there. The third division, or the mandibular division, is of special importance because, as I mentioned just a second ago, there are motor fibers that are traveling with the trigeminal nerve. Well, all of the motor fibers will actually travel with V3, the mandibular division. And these will be distributed to the muscles of mastication and muscles called mylohyoid and anterior belly of digastric, and of course the tensor tympani and tensor veli palatini. Don't worry about the small muscles first. The big picture is muscles of mastication. So if we focus on the sensory distribution, well, the ophthalmic division and the maxillary division and the mandibular division, they're going to innervate very specific regions of the face. Let's see if we can maybe find us a picture with the dermatomes. And voila, here we can see the distribution now of the ophthalmic, the maxillary, and the mandibular division of the trigeminal nerve. So you can see that V1 covers a large amount of the scalp, all the way up to, just the tip of the ear here, and it goes all the way over to the other side. And it also covers the region of the upper eyelid and all the way to the tip of the nose. Not the sides of the nose, though. V2, the maxillary division, runs as this sliver for the lower eyelid and the sides of the nose, including the nares or nostrils, but stops at the sides of the mouth or the lateral angles of the mouth. And V3, then, the mandibular division, actually the nerve is called the mental nerve, comes out of the mental foramen down here and distributes all the way around here. So V1, V2, and V3, that is the sensory component. Now we're probably going to have a look at some more details for the individual divisions. Alright, so V1, the ophthalmic division of the trigeminal nerve, we can see here, well, the ophthalmic division passes through superior orbital fissure. Okay, here is the trigeminal ganglion, that is the trigeminal nerve. Here's the ophthalmic division, and first and foremost, the ophthalmic division or ophthalmic nerve only does somatic sensory. Yeah, passes through superior orbital fissure, as you can see here, supplies quite some important things, like, for instance, your cornea, your upper conjunctiva, mucosa of the anterior superior nasal cavity, so inside the nose here. The sinuses, well, at least the frontal and ethmoidal sinuses, part of the dura, and the skin of the back of the nose, which I showed you a little bit earlier on. Fairly similar, at least in regards to what it can do. The maxillary division of the trigeminal nerve also can only do somatic sensory. It does pass anteriorly through the foramen rotundum, which is called foramen rotundum because it's a round hole. The mandibular division will go through the foramen ovale, but about the maxillary division, after it passes through foramen rotundum, it'll supply the skin on the cheek and on the face here. In addition to that, it'll also do some of the conjunctiva of the inferior eyelid, some of the mucosa of the nasal cavity, mainly though the posterior aspect of it. Also the maxillary sinus, which is, well, within the maxilla here. The teeth of the maxilla, this is why this nerve or this division has to be anesthetized if you have dental work done here. And the upper lip. The most substantial part of the trigeminal nerve or trigeminal ganglion is the mandibular division, down here. It passes through a oval opening called the foramen ovale, and It emerges through a foramen ovale down here. See if I can zoom in a little bit more. Sure enough, here it is passing through the foramen ovale. You can already see that it will then give off a couple of branches, and then it'll pierce an opening within the mandible, which is called the mandibular foramen. And you can see here how the nerve splits off a little nerve here. This is the nerve to the mylohyoid, and the nerve exits right here through the mental foramen. Okay, now putting that together in the context with the sensory distribution, that all kind of makes sense, doesn't it? No pun intended. Upon emerging through the foramen ovale, this is something quite interesting. If I have a look at this, we can see that there's several branches that get split off, and they have different names. For instance, there is a branch that goes over to the side, it goes close to the ear and the temporal region, so that nerve is going to be called the Auriculotemporal Nerve. Here's the Auriculotemporal Nerve, and I would say it's probably the most famous or most significant branch of V3. Careful with that statement, only because here you can see that it seems to be a loop. Well, it is a loop because usually, I'm saying usually because that's just generally the case, usually this nerve, the oculotemporal nerve, will form a loop around the middle meningeal artery, which will actually be a branch of the maxillary artery and go through the foramen spinosum, very close to the foramen ovale, and supply the meninges. Okay, the auriculotemporal nerve is a branch of V3. So is the Mesoteric Nerve. If you're going to do this in lab, though, please be aware this nerve has probably been destroyed because most people, they cut the head of the mandible, they cut the coronoid process, cut the zygomatic process out, and you know what? The Mesoteric Nerve is going to be sacrificed in that process. There are also some more deep temporal nerves here. Here's a sensory nerve called the buccal nerve. Yeah, it does sensory to the cheek. And if we have a look at the inside here, here's the lateral nerve, which is also a branch of V3 that will supply the anterior two-thirds of the tongue with general sensory innervation. However, don't want to jump the gun here, it will also convey some fibers that have been hitching a ride that will convey special sensory. Okay, the special sensory, and actually also parasympathetics, are hitching a ride via a different cranial nerve number 7. We will get there though. The components mediated or conveyed from the trigeminal nerve itself are purely sensory. So now, after we've had a slightly more elaborate nerve, cranial nerve number 5, the trigeminal nerve, now we have a very simple one again, which is called the Abducens nerve. The Abducens nerve is interesting because it is the other one nerve that only innervates one extraocular muscle. In this case, see if you can deduct the function of the muscle that innervates just from the name, Abducens nerve. So it sounds a little bit like abduct, and indeed, the function of the muscle that is innervated by the abducens is to abduct the eyeball from the primary position, so from the forward gaze. And so this muscle is called the lateral rectus. Yeah, and the lateral rectus is innervated by the Abducens nerve. And the only thing that this nerve provides is going to be somatic motor and proprioceptive information from the lateral rectus. It's a fairly small nerve as well, and it comes down here from the brainstem. Let me zoom in. Between the pons and the medulla oblongata. See how close we can get? Yep. between the medulla oblongata and the pons. And it'll also traverse the pontine cistern of the subarachnoid space. If we see how long this nerve is, see, it runs all the way over here, pierces the dura, of course, eventually. But intracranially speaking, it does run the longest course within the cranial cavity of all the cranial nerves. Who would have thought? And something that's actually a little bit more interesting, or should I say important, is that the course of the abducens nerve, we've talked about a couple of nerves and their proximity to the cavernous sinus, right? Well, the abducens nerve actually runs right through the cavernous sinus, okay? Get your bearings for a second. Let me get a little bit closer into the cranial cavity here. The abducens nerve travels through the cavernous sinus. Now, if we were to add back in the veins and everything else, it would get incredibly busy. But the key thing to know is that the abducens nerve travels through the cavernous sinus, so it's basically bathed in this sinus and all the veins that are carrying blood, and it's supposed to flow from the cranial cavity outwards. And in the end, it'll actually exit via ophthalmic veins, and then the angular vein and facial vein and so on and so forth. The problem is, if you think of cavernous sinus thrombosis, well, veins in the face don't have valves. You can reverse the flow of blood, and that can lead to infections that can spread into the cavernous sinus with that there then the cranial cavity, and then you have a lot of trouble because you have an infection. Often this is Staphylococcus aureus, and that is in the cranial cavity. However, as the abducens nerve is pretty much exposed within the cavernous sinus, this is going to be the first nerve where you can actually find clinical issues. So it will not be able to abduct the eyeball anymore. So someone who has an abducens nerve palsy is going to have a permanently medially rotated or adducted eyeball, because we have the lack of the abducting function of the lateral rectus. So, in a nutshell, the abducens nerve only provides somatic motor and proprioceptive information for one extraocular muscle, and that is the lateral rectus. Second, it has the longest intracranial course. Third, and probably most importantly, due to its course through the cavernous sinus, this is the most exposed nerve, and so this is the first nerve, and then with that subsequently the muscle associated with it, that you would actually expect to have clinical symptoms with if you have cavernous sinus thrombosis.